Okay, next up, and by the way, I love that you're all getting snacks and taking care of yourselves. There are snacks and beverages in the back if you want to just pop up and get some. But I would like to move forward so that we stay on track. And our next presenter is Dr. Jordan Rullo. She is she has a PhD. She's an ABPP board-certified clinical health psychologist, certified sex therapist, and supervisor through the American Association of Sex Educators, Counselors, and Therapists, and a certified Gottman therapist. She is an adjunct assistant professor in the Department of Clinical Psychology at the University of Utah. She has a private practice in Salt Lake City, and she teaches online sexual health courses. Her areas of specialty include couples and sexual health, sexual dysfunction, and sexual health related to menopause and cancer. She presents on sexual health nationally and internationally and has published over 24 peer-reviewed articles on the topic of sexual health. She is truly an expert. She has spoken with Reborn on several occasions. I know she has spoken at other breast cancer-related events. There you are. I saw you at the back earlier. She is just a wonderful partner for Reborn to educate on these topics and help us learn more about sexual health and what it means. So please welcome Dr. Rullo to the podium. Do you prefer this or the handheld?
I kind of like to move.
Okay, I thought so. Let me grab that for you.
And then, oh wow, that's fancy.
I know. I don't know if you want this fed through, but when you're ready, green light, let's go.
Where's this thing going? Down here?
Yeah, just kind of,
This is like Madonna.
I know. Or CIA.
Or CIA, yeah. Or McDonald's.
How's that feel?
That feels good.
Okay.
And then you said when I'm ready, hit this button.
Yeah.
Oh, and what about a remote as I'm walking around? I mean, I brought my own remote. I can plug it in.
Oh, yeah, if you want to just, you can just take one of these out. And then, I can't remember how you do this. Do you want a slideshow?
Go down there.
How
Oop,
often
no.
I have to do public presentations.
And I don't. Oh, good, we got it. Let's make sure this works. Great. Great. And this works? Oh, good. And then you say I just push it. Green. Hello, hello? Can y'all hear me? Oh, yay. Look at this fun thing. I didn't realize I'd get one of these fancy things. I am nursing some allergies, so just bear with my voice as I'm talking today. You'll just hear a lot of like, and I'm so sorry. I brought some tea so I can try to keep my voice up for the hour, for the 50 minutes. Well, thank you all so much for being here. Super excited to talk about sexual health. Also, thank you, Dr. Moreno, for an amazing talk. I'm going to be referencing back to her talk many times. Oh, right there. Hi. Okay, so I'll be talking about the impact of breast cancer on sexual health. What I really want you to take away from this is that breast cancer does not take away your sexuality. So if you only remember one thing from this entire presentation, is that breast cancer does not take away your sexuality. So let's jump in. I'm going to be talking about 3 different women. So first I'm going to introduce you to these women, and then I'll go on to talk about each of them. So the first one's Sarah. She says, I have no sexual interest. If I didn't have sex for the rest of my life, I'd be fine. She's a 38-year-old heterosexual married woman. She's had breast cancer, status post total abdominal hysterectomy, and bilateral salpingo-oophorectomy. The second woman we'll talk about is Nancy. And she says, we haven't had sex in 5 months. It hurts too much. I'm desperate. She's a 49-year-old heterosexual married woman, breast cancer, status post-total abdominal hysterectomy, and bilateral salpingo-oophorectomy. And then finally, we'll talk about Kelly. And Kelly says, I can't even look at my breasts, let alone let my wife look. I haven't let her touch me since my surgery. 29-year-old lesbian married woman, stage 2 breast cancer, status post-bilateral mastectomy. So we'll talk about all 3 of these women. Now, before we get started, I've got a little quiz. You can't fail this quiz. I'm just curious. Between what percent and what percent of breast cancer survivors have sexual health concerns? What would you say, like 5 to 10%, 30 to 50%? Just yell out a couple numbers. Yeah. So you've taken this test before. Wow. Yeah, between 70 and 90%, depending upon the research study that you look at, of breast cancer survivors report sexual health concerns. I don't have to tell you this. You all already know this. You're experiencing this. Here's the thing. Sexual dysfunction doesn't get better over time. So if you've ever had a provider tell you, like, oh, just wait a few more months, things will get better, or that pain will go away, that is not true. It does not get better over time, but here's the upside of this. Unless treated, and there absolutely is treatment, and we'll talk about this today. So what do you do? If you're experiencing sexual health concerns, what do you do? First of all, again, breast cancer does not take away your sexuality, and there absolutely is treatment for these sexual health side effects. And we're going to be talking about these specific side effects today. We're going to talk about low sexual desire, sexual pain, poor body image, and if you're in an avoidant sexual dynamic, meaning you and your partner are avoiding sexual activity. And we'll talk about how to treat each of these and then how to navigate your sexual relationship around these. And we're going to start with low sexual desire. And in order to get into this, we're going to talk about Sarah. Again, I have no sexual interest. If I didn't have sex for the rest of my life, I would be fine. If any of you are thinking like, oh yeah, this sounds like me, pay attention to this part. Yes, you're saying the me, yes. To tell you a little bit about how to address what Sarah's going through, first we got to talk about the two different types of sexual desire, because there are actually two different types of sexual desire, and most people don't know this because either we didn't get sex education, or if we got sex education, it didn't talk anything about sexual desire. It probably talked about not to have sex and the STIs you get. So let's talk about the two different types of sexual desire. The first type is called spontaneous desire. And that's that type of desire where we have that internal drive, that internal craving, and you just think, I really want to have sex right now. So that's spontaneous desire. And that's the one you see in movies and media. And the second type of desire, which is equally important that probably most of us don't know about, is called responsive desire. And responsive desire looks like this. You are sexually neutral. Sex is not on your mind. You are not thinking about it. But the right ingredients are in place for you to be responsive or potentially open to sex. And so maybe those ingredients are you've got good energy, you're feeling good about your body, there's privacy, and your partner initiates. Or maybe if you don't have a partner, you just see something sexy on television, and you're like, oh, well, I wasn't thinking about sex, but I feel good, I've got good energy, there's privacy, yeah, I could be open to that. And then once the sexual activity gets started, then you're like, oh yeah, this is kind of nice. Well, we should do this more often. That's responsive desire. So it starts from a place of being sexually neutral, and then things have to get kick-started. So let me show you responsive desire pictorially. This is called, I know this looks really confusing, but I'm going to walk you through this. This is called the circular model of sexual response. And probably most of you, this is how you sexually respond, but again, I'm going to walk you through this. So circular model, not a surprise, it's a circle. There's two ways you can jump into this circle, two ways that you can kind of kickstart your sexual response. So for some of you, the main way you kickstart your sexual response might be that you just happen to have that spontaneous sexual drive. And then that makes you feel aroused in that moment, or you're seeking out some sort of sexual stimuli. So this might be what kickstarts this whole cycle. But for most of you, especially because of the impact of breast cancer, and we'll talk about the impact of breast cancer on sexual drive, for most of you, this is probably not what's getting you in your sexual response cycle. What's probably getting you in your cycle is that you are receptive, you are responsive. So let's say you're receptive, you're responsive, there's some sort of sexual stimuli, let's just say it's a partner initiating sex. As long as biologically and psychologically everything's in check, meaning you don't have a major headache, you're not having hot flashes, you're not having a bunch of aches and pains, so biologically you feel pretty good, psychologically you feel pretty good, you're not super stressed in that moment, you're not feeling depressed. So as long as things are in check, what needs to happen first is your body has to get aroused first. And this is super important. We'll come back to this later on in my presentation. But your body has to get aroused first, meaning there's something that has to kind of kickstart this desire. So when I say this, this means if your partner says like, hey, you want to have sex tonight? They're not going to do it. It's not going to do it because nothing is kickstarting this arousal. There has to be maybe some touch, some massage. There is something that has to impact your body to kickstart that arousal. And then once that arousal gets going, Then the desire, where your mind kicks in, then the desire comes on the coattails, and you go, oh, yeah, kind of like this. Okay, I'm into this. But body has to get started first, and then the desire comes. And then, hopefully, this leads to some sort of emotional and physical satisfaction. Some people describe the satisfaction they get from sex as being orgasm. Some people say it's the skin-to-skin contact. Whatever satisfaction is for you, and then that leads you to feel emotionally close to the person you're being sexual with, and then that leads you to seek out and be receptive toward future sexual stimuli. So this really is responsive desire in action. And we're going to come back to this, but it's so important to know that responsive desire has to get kickstarted by something that kickstarts that arousal, which usually, for most people, is some sort of touch. Okay, now, I mentioned before that breast cancer changes your sexual desire. So anything that's going to impact your hormones, like any sort of treatment you're on for breast cancer, entering menopause, treatment-induced menopause, anything that's going to impact your hormones more than likely is going to impact your desire. So if you think about spontaneous desire having a gas tank, most of the gas that fills that gas tank is your hormones. And you see I have in parentheses indirectly. Okay, so let me try to explain this. If someone just gave you a ton of estrogen, that doesn't mean that all of a sudden you're going to go, oh my gosh, I want sex. Indirectly, that estrogen helps your desire. So when you enter treatment-induced menopause or menopause, like Dr. Moreno mentioned, there's all those symptoms. The hot flashes, the night sweats, you're not sleeping well, you've got brain fog, all the genital urinary syndrome of menopause symptoms, the vagina's dry, there's pain with sex. So all those symptoms, that is what takes a hit on your desire. You're not feeling well. You're not going to want to be sexual. You're really exhausted. So when you get hormones and it takes away a lot of those negative symptoms, then women say they feel like their desire increases. So hormones fill that gas tank indirectly. The second thing that fills that gas tank that we know is the honeymoon phase. So if you're in a relationship, the honeymoon phase, here's what the research says, is the first 12 to 36 months. Actually, in the research, it's called the limerence phase. But really, those first 12 to 36 months, your partner is adorable. They could burp, and you're like, oh my gosh, this is the sweetest burp I've ever seen. That does not last any more than 12 to 36 months, and then you go into what I call the sweatpants phase. So what do you do if you don't have those hormones and you've been in a relationship that's been in over 36 months? There's no magic way to fill that gas tank again. So really, you've got to be thinking about tapping into your responsive desire. That is going to be your predominant desire. So now, how do you tap into that responsive desire? There's a really cool model called the dual control model. It doesn't sound fun, but this is incredibly helpful to tap into that responsive desire. So the dual control model is based on this idea that for all of us, when it comes to our sexual function, and specifically we're talking about sexual desire here, we all have a brake pedal and a gas pedal. And in order to tap into that desire, you have to have more on your gas than on your brake. Now, for example, things that hit the brake. If you're feeling bad about your body image, if you're tired, if you're on chemo, if you're feeling depressed, anxious, stressed out, all of those things, of course, are going to hit the brake pedal. Things that could hit the gas. If your partner smells good, they look good, maybe there's some novelty in the relationship, maybe there's a really strong emotional connection, all of those things can hit the gas pedal. So now here's the deal with this brake pedal, gas pedal analogy. Again, you've got to have more on the gas than on the brake in order for you to tap into that responsive desire. Most of the time when I'm seeing clients as a sex therapist, and they say, I've got low desire, I've entered menopause, my desire has declined, I want, my treatment goals, I want to improve my desire, and I ask, okay, well, what have you done? And what have you tried? And they'll always say, most of the time they'll say, they've tried gas pedal stuff. Oh, we've tried date nights and lingerie and toys. And although at some point that may be helpful, at the beginning, that is typically not helpful, and here is why. If you think about this brake pedal, gas pedal, think about this as a brake pedal and gas pedal in a car. If you have your foot pushed all the way down on the brake, and the brake is all the way to the floor, and then you say you're going to put your foot on the gas, what's going to happen to your car? Yeah, it might rev a little bit. It's not going to go anywhere. So if you have a ton of weight on that brake pedal, the gas pedal is irrelevant. And so this is really the start of treating low sexual desire or tapping into that responsive desire. The start is trying to figure out what is on the brake pedal. Once you can identify all the different things that are on the brake pedal, how much weight those different things have on the brake pedal, and then you can start to remove some of that weight off the brake pedal, then after that, you can start thinking about gas pedal. But initially, gas pedal stuff's not going to be very helpful when you have a ton of stuff on the brakes. Now, here's another model I want to show you. Again, it doesn't sound fun, but it's actually really helpful. This is called the biopsychosocial model. This is a really, really great way to organize and identify all the potential things that are on your brake pedal. So as I'm going through, I'm going to go through the most common things that hit the brake pedal, especially for women with breast cancer. I want you kind of thinking in your mind, oh, does this hit my brakes? Does this hit my brakes? Really start to kind of take inventory of the things that are hitting your brakes if low desire is something you're dealing with. So biopsychosocial model goes through 4 quadrants: physiologically, psychological, emotional, interpersonal relationship, and then socio-cultural influences. So I'm going to go through each of these and the most common things that hit the brakes in each of these categories. Okay, physiologically, chemotherapy, right? If you're actively on chemotherapy, that absolutely is going to hit the brakes. Medications for breast cancer, specifically things like aromatase inhibitors, but also antidepressants, really common brake hitters. Genitourinary syndrome menopause. Dr. Moreno talked a lot about this. The biggest reason this hits the brakes is it causes pain with sexual activity. With GSM, genitourinary syndrome menopause, when it comes to the vulva and vagina, everything just dries out. You lose that elasticity. The blood flow to the vulva and vagina declines. So you've got less arousal. So typically there is pain, and you're also just not feeling the same vaginal sensation that you felt before, sexual arousal that you felt before. Hormones, like I mentioned before with the gas tank analogy, anything that impacts your hormones is going to impact your sexual desire. And fatigue. So what I'll ask my clients who experience low desire, I'll say, okay, at the end of the day, if someone were to hand you a platter of sleep versus a platter of sex, what platter are you going to take? And if they say the sleep platter, then my guess is fatigue is probably something hitting their brakes. Most common psychological, emotional issues that hit the brakes: anxiety. When you are anxious, your mind is basically telling you that there is a threat and that you need to be scanning the environment for that threat. Let's say you have your 6-month or 3-month follow-up with your oncologist. I imagine you're feeling pretty anxious and you are scanning the environment for that threat, worried about that appointment and what's going to come up. So when we're anxious, it's incredibly difficult to relax. There's this rush of adrenaline, this rush of cortisol. And a prerequisite to being sexual is to be able to relax. But if you're constantly looking at the environment for threats, it is difficult to relax, which means it's not going to allow blood flow to your genitals, to your body, and then it's going to make it difficult to have desire. Depression. Hallmark features of depression are that you've got low motivation, the things that used to feel good don't feel good, low sexual desire is a hallmark feature of depression. So if you're experiencing depression, that absolutely is going to reduce desire. Poor body image. If you don't feel sexy, it's difficult to want to be sexual. History of sexual abuse or trauma, especially if this is untreated or unprocessed, you haven't had a chance to go through that trauma that you've had, and now it's being triggered in your sexual experience. Distraction. So when I work with clients, I ask them about the 2 different types of arousal, because there's actually 2 different types of arousal as well as 2 different types of desire. The one type of arousal is the one we all know about, that physiological arousal, blood flow to genitals, vaginal lubrication. But the other type of arousal is your mind arousal. So what's actually going through your head when you're being sexual? So I'll ask my clients who say they have low desire, I'll say, well, what are you thinking about? When you're actually having sex, what are you thinking about? Because I'm trying to assess how's their mind arousal. And oftentimes I get things like, oh, my to-do list, and if the kids are going to come in the room, and like, that's not sexy. Of course that's going to reduce your desire. And then finally, substance abuse. So a little bit of substances can be helpful to reduce some inhibitions to be sexual, but more than just a tiny bit, and it's really going to put a damper or a wet blanket on your sexual function. Okay, interpersonal relationship factors that hit the brakes. Conflict. If you're arguing with your partner, you probably don't want to have sex with them. No emotional intimacy. When I was going through that circular model of sexual response, emotional intimacy was that top box. Emotional intimacy is a huge driver for that responsive desire. If you don't have that, that's a huge break in that cycle. So feeling emotionally connected to your partner is really important for desire. Partner dysfunction. We know that if your partner has a sexual dysfunction, if you have a partner that's a male, if they have erectile dysfunction or premature ejaculation, that's going to increase the likelihood that you have sexual dysfunction concerns. Inadequate stimulation. If the sex you're having is not pushing the right buttons and it's actually not that enjoyable, probably not going to want to have it. And then lack of privacy. I mentioned in the slide before that, so I always ask my clients, so when you're having sex, what are you actually thinking about? And so many times I have heard clients say, like I mentioned before, I'm worried that the kids are going to come in the room. So whenever I hear that, I'm like, oh, just lock your door. And I have heard numerous times, oh, we actually don't have a door in our bedroom. And I'm like, what? First part of the treatment plan is to go to Home Depot and install a door. And then lastly, sociocultural influences. So limited sex education. If you don't know about the difference between spontaneous and responsive desire and how to tap into that, that's going to impact your desire. Conflict with religious, personal, or family values. I see this a lot here in Utah with the practice in Salt Lake City. A lot of negative messages that come from from religion that really can put a lot of shame on sexuality. And then societal taboos. I've talked to many women who say, I actually do have desire, but I don't feel like I should be initiating. Like women shouldn't initiate. So taboos about what it means to be a woman or women's sexuality. So what I would recommend, whether you want to do this now or after the conference, especially with your partner, if you have a partner, even better, is to actually take a piece of paper and write out the biopsychosocial model. So this essentially is the biopsychosocial model. We got biological, psychological, relationship, and then I just put the sociocultural under kind of a life stuff category. But really, take out a piece of paper, put down these 4 quadrants, and try to think about what are all the things that are hitting my brakes. And maybe the typical woman with breast cancer, she would say, I'm having hot flashes and night sweats, so I'm not feeling very good about myself. I've had weight gain. I'm not feeling good about my body. My partner and I have been arguing lately, and I'm in that sandwich generation, and I'm exhausted because I'm taking care of kids and I'm taking care of parents. So this might be the typical biopsychosocial model. I can tell you when I work with clients, there are so many more things listed on here. And then I want you to take a look at what you have listed and ask yourself, of all of these things that you have listed, what are the top 3 that have the greatest weight? So really, what are the top 3 that have the greatest weight on your brake pedal? And once you identify those top 3, that becomes your treatment plan. I want you to start working on ways that you can potentially reduce those top 3. So if you say it's fatigue, then start working on better sleep hygiene. If it's conflict with your partner, consider maybe couples therapy or talking with your partner. But those top 3 things that have the greatest weight, that's where I want you to start. Because remember, if we go back to this brake pedal, gas pedal, the gas pedal is irrelevant if you have so much hitting that brake. So you got to remove as much as possible off that brake pedal. That is how you're going to most tap into your responsive desire, this brake pedal, gas pedal. These books are phenomenal. They talk about the different types of desire. They talk about the brake pedal, gas pedal analogy. So the first book, Come As You Are, and then it has this accompanying workbook, the Come As You Are workbook. I recommend these to my clients all the time. And what I would highly recommend, especially if you have a partner, I would want both of you to get this book. Read it. The author does an audiobook that's pretty entertaining, so if you don't like to read, you can listen to the audiobook. And then I would want both of you together to do the workbook together. This is incredibly, incredibly helpful. So here's the take-home on low sexual desire. 2 types of sexual desire, spontaneous and responsive. With hormonal changes that could be the result of chemo, AIs, oophorectomy, your responsive desire is going to become your predominant desire. So really try to maximize that responsivity by figuring out what ingredients need to be in place, and then talk to your partner about these ingredients. All right, so let's go to the next one. We're going to talk about sexual pain. And sexual pain brings us to Nancy. Nancy says, we haven't had sex in 5 months. It hurts too much. I'm desperate. Okay, so what does Nancy do? Let's talk a little bit about breast cancer and sexual pain. The sexual pain is typically caused by what Dr. Moreno described, genitourinary syndrome of menopause. What causes genitourinary syndrome of menopause? Typically treatment-induced menopause. And what treatment is inducing that menopause? Surgery, chemo, aromatase inhibitors. And induced menopause versus natural menopause, and Dr. Moreno touched on this, when all of a sudden you wake up from a surgery because your ovaries have been removed, induced menopause, or you're on chemo, or you're on AIs, versus natural menopause, where you've had years to allow your body to get used to those fluctuating and declining hormones. Induced menopause, that sudden onset, you have more severe symptoms, and it may not entirely respond to hormone therapy. So induced menopause is just so much more difficult than entering natural menopause. And so when you go through menopause, you lose all that estrogen. You no longer have that estrogen, as well as other hormones, but I'm going to focus on the estrogen because estrogen is so incredibly important for sexual function. So estrogen helps you maintain the physiological function of your genitals. So if you think about your vulva and vagina have tons of estrogen receptors. And when you enter menopause, all those estrogen receptors are no longer getting fed with estrogen. So then what happens with the vulva and vagina when it doesn't have that estrogen is everything dries out. You lose that vaginal elasticity. So instead of the vaginal opening being elastic, now it can rip and tear with penetration. That the vaginal tissues become thin. Oftentimes they're described like sandpaper. They also can rip and tear. And then what estrogen also does, in addition to the elasticity and the lubrication, estrogen helps facilitate blood flow to the genitals. And blood flow is really important for sexual arousal. If you don't have estrogen and it's not helping facilitate that blood flow to your genitals, then it's more difficult to get sexually aroused. You're not feeling the same level of sexual sensation that you felt before. It's more difficult to reach orgasm. So without that estrogen, there's just a huge wet blanket on genital function, and there can be that pain. So estrogen is so important for genitals. Like I mentioned, it's critical in preserving vaginal sensation, lubrication, preventing sexual pain, promoting sexual arousal. If you're having painful sex, here is my recommendation. And the first thing I'm going to say here, you're going to be like, duh. But I do really want to share this. Step one is to stop. And the reason why I say this, even though it does seem like a duh moment, is I have so many clients that I work with that really think, well, if I just keep doing it, it'll get better. The pain will get better. Maybe I have to kind of work out some muscle or something and the pain will eventually go away. Or I've worked with women who say, well, shouldn't penetrative sex always just be a little bit painful? No. Sex should not be painful, even a little bit painful. And so here's what happens if you continue to have painful sex. If you think, well, maybe it'll just go away over time, or I guess it's just a little bit painful. What happens is every time you have sex and there is pain, so sex, pain, these get conditioned, connected in your mind. So when you even think about sex, what is the first thing that goes through your mind? Pain. And what this also translates to is maybe your partner goes to touch you and you think, oh, they're initiating sex. Oh, it's going to be painful. Don't touch me. So it's really damaging if you continue to have painful sex because you're just strengthening that connection between pain and sex. So we got to stop strengthening that connection. That's number one. And then I mentioned before, it leads to this avoidant dynamic. This avoidant dynamic is the most common dynamic I see in my sex therapy practice. And so let me describe this to you. So the avoidant dynamic starts like this, where one partner wants to have sex, they initiate sex, and the other partner says, like, this is painful, I don't want to do this. And so this other partner says, well, like, I don't want to pressure you in any way, so I'm not going to initiate. You come to me when you want sex. Well, if it's painful, you're not going to be initiating with your partner. So then what happens is both of you are avoiding. And this avoidant dynamic has this really gnarly ripple effect. So first, it starts off with both of you avoiding sex. But then as that goes over time, what happens next is you both start avoiding that non-sexual physical connection. So like I mentioned before, you start to connect pain and sex in your mind. So your partner comes up to touch you or wraps their arm around you, and your mind goes straight to they're initiating sex. This is going to be painful. Nope. So you start avoiding that non-sexual physical touch. And then your partner's like, ooh, every time I touch you, you flinch or you pull away. So like, I'm not going to touch you. You can come touch me when you want to touch me. So now both partners are avoiding that non-sexual physical touch. And then over time, and this is often when couples finally come to see me as a sex therapist, over time, the last ripple is to that emotional connection. And that's where the couple says, we just feel like roommates. So this avoidant dynamic can be really damaging over time. And we're going to talk at the end of this, toward the end of the presentation, about how you can avoid the avoidant dynamic or how you can pull back if you're in it, how you can reverse it. So step 1, stop having painful sex. Step 2, think about over-the-counter options. And Dr. Moreno talked a bit about these. And think about creating a new sexual menu that does not involve anything that is painful. Okay, so let's talk for a moment about over-the-counter options. I'm going to repeat a little bit of what Dr. Moreno said, but I'll go into a few more details. Moisturizers are excellent over-the-counter options. Moisturizers are, I had an old colleague who called these face cream for your vagina. I mean, technically it's face cream for your vulva. But so just like you wake up in the morning, and most of you probably put on some sort of moisturizer and it's a part of your daily routine, that's what moisturizers are for the vulva. Every single day or 3 to 5 times a week, you got to figure out your cadence. You're putting these on, unrelated to sexual activity. It is the cumulative effect of putting on the moisturizers that helps trap in that moisture and helps make that layer of your vulva feel thicker and just more moisturized on a daily basis. So moisturizers are just a great thing to do on a daily basis or multiple times per week. Replens is a super common moisturizer that you can get at the grocery store, but Hylogyne has been specifically studied in breast cancer survivors. That one you have to buy from their website. Then lubricants. So lubricants, like Dr. Moreno mentioned, are as needed for friction reduction. This is what you use in the moment for sexual activity. And you can put it on yourself, you can put it on your partner, you can make it a part of the sexual experience. You can be like, this is fun. I mean, you two can just have fun with it. So lubricants, there are different bases of lubricants. There are water cone-based lubricants, silicone-based lubricants. There are other bases I'm not going to talk about. I'm just going to talk about these 2 bases. Water-based lubricants are kind of your best bet. There's no contraindication to a water-based lubricant. Sliquid is a great company that sells a lot of different lubricants. The one I have up here is called Sliquid Organics, if having an organic lubricant is important to you. The only downside of a water-based lubricant is because the base is water, it evaporates quickly, so you need to apply it repeatedly. One little trick is if you have a glass of water by the nightstand and the lubricant starts to dry out a little bit, you can dip your fingers in that water, touch the lubricant, and it kind of reactivates the lubricant a bit. But you really can't go wrong with a water-based lubricant. The other lubricant, a silicone-based lubricant, pink is one that I often recommend. A silicone-based lubricant is great because it lasts a long time. It is incredibly slippery. It is so slippery that if you honestly drop some on the floor, you would slip on it. It's super slippery. But what's great about that is it's great in the shower. You can maintain it while you're taking a shower. You don't have to be reapplying it. However, with a silicone-based lubricant, there are some contraindications. If you use any sort of sex toy or sexual enhancement device that's made out of silicone, like a vibrator made out of silicone, there is some research to suggest that a silicone lubricant will degrade your silicone sex toy. I've actually not seen that happen in real life, but sex toys can be really expensive, so I don't even want to try it. So if you have a silicone sex toy, maybe you don't want a silicone lubricant. The other thing is, because it is so slippery, if you have a male partner who has any sort of erectile difficulties, it can reduce so much friction that it may make it difficult for your partner to keep or maintain their erection. So those would be the 2 main contraindications for silicone. Oh, and it can stain your sheets. We'll add that. The other option, kind of low-hanging fruit option, is to consider a new sexual menu that does not cause pain. So non-penetrative sex. There are so many different ways to be sexual that don't involve penetration. If penetration is predominantly what's causing that pain, consider a non-penetrative sexual menu. There's going to be a link at the end of this talk where you can download a sexual menu from my website of all different non-penetrative sexual activities. The menu actually has a rating scale up top of 1, I don't want to do this, to 5, ooh, that sounds fun. And so print out 2 of the menus, 1 for you, 1 for your partner. Both complete the menu, put your ratings on there, and then compare all the things that you rated really highly that you'd be interested in engaging in. Also, there are a couple really good online menus. They're a bit more adventurous than the menu on my website, just to give you that warning. But Mojo Upgrade and We Should Try It, and it kind of does the same thing. You create a login, your partner creates a login, gives you a ton of different sexual activities, and then you can indicate all the things you're interested in, and at the end, it gives you a printout of all the things you and your partner said you were interested in. Vibrator is a great accessory to add to your sexual repertoire, to your sexual menu, especially if you've entered menopause, like I mentioned before, with less estrogen. That means less blood flow to the genitals. That means less sensation. If you have less sensation, you're going to need more powerful stimulation. So if you've entered menopause and you're like, ugh, it is much harder to reach orgasm, vibrator would be a great option. That gives you that more powerful stimulation. 53% of women have used a vibrator. When you ask women who have sex with women, that number jumps up to 85%. These are a couple different vibrator styles. This is more that bullet or egg-shaped style. This is not inserted. This is just external, so for like clitoral use. And this is a vibrator that you could use both internally and externally. If you are new to vibrators and you're thinking about buying one, I would really recommend buying one where you have more options of what you can do with it, both internal and external. These are from a company called Lelo, L-E-L-O. I really, really love Lelo vibrators, but they are like the gold standard of vibrators and they're very expensive. But they're all made from medical grade silicone. Silicone is really the easiest vibrator to clean. It doesn't have nooks and crannies that keep bacteria. So if you ever see a vibrator like on Amazon that's like jelly rubber or cyber skin, too many nooks and crannies, too difficult to clean. What you want is a vibrator that is made out of silicone. Vibrators are great for sexual satisfaction. They're great to increase that blood flow. So here's my prescription, my vibrator prescription. I'd recommend silicone, something that's for internal and external use so you can try different things. Just clean it with soap and water afterwards. Make sure you clean it after every use. Don't share it with others. I loved when Dr. Moreno was like, your friends can put in your ring, your vaginal ring. I would say, don't share this with your friends. And don't switch it between orifices. So anus, vagina, no. Okay, so we got step 1, we got step 2, now step 3, and Dr. Moreno talked mostly about this, so I'll go quickly through this part of my presentation, but prescription options for genitourinary syndrome and menopause. Vaginal estrogen increases the pelvic blood flow, increases that lubrication and elasticity. Like I mentioned before, the vulva and vagina have tons of estrogen receptors. When you enter menopause, all those receptors dry out. So what do you do to treat those symptoms in the vulva and vagina? You give it estrogen. And like Dr. Moreno mentioned, if you are just doing localized estrogen, that is estrogen just to the vulva and vagina, what she mentioned is that is not then, that estrogen is not then being taken up throughout the rest of your body. So I think she gave two studies that showed that local estrogen is safe, for the most part, for breast cancer survivors. Susan mentioned a little bit earlier the incredible importance of advocating for yourself. I cannot tell you the number of clients I've talked to, breast cancer survivors who have said, cancer survivors in general, who have said, oh, I talked to my oncologist and because I wanted to get on estrogen, and my oncologist said, no way, No, push back. Push back. A lot of oncologists have not done a deep dive into the sexual health research, and so it is absolutely up to you to say, wait, I heard something different at a conference. If you don't have the answer, then I want you to tell me who has the answer, or I want you to take the time to find the answer, but I heard something different at a conference, and I want to know what the research is. Because vaginal estrogen, for the most part, I think there's a small caveat, is safe for breast cancer survivors. It's just localized estrogen. It increases that genital tactile sensation. So just like Dr. Moreno mentioned, there's creams, there's rings, there's tablets. You would talk with your doctor about what your options are. There are some other options that I will just go through quickly because Dr. Moreno mentioned them. So if you don't want to actually be on hormones and that still kind of worries you, DHEA progesterone, like Dr. Moreno mentioned. Again, I'll go through this quickly. She mentioned all this stuff. Unless something has changed, Dr. Moreno, please check me on this. It's FDA approved for sexual pain, but it's not yet approved for those with breast cancer. Okay, that's correct, yes. Then we got ospemifene. It's a pill. It's a SERM. Not going to go into this stuff. Dr. Moreno did. Also FDA approved for sexual pain and vaginal dryness. Not yet approved for those with breast cancer, unless Dr. Moreno corrects me, which is not great. Vaginal lasers. Dr. Moreno talked about this for a moment. I'm going to add one little piece here. So vaginal lasers are fascinating. I have a lot of clients that ask me about these. The vaginal laser, so here's the laser going inside the vagina. The laser is basically injuring the tissues to encourage healing healthier tissue. So that's like, in a rudimentary way, what's happening. And there was a really interesting 2021 study that compared vaginal laser to a fake laser. So basically they recruited 85 women and Half those women got a fake laser, half those women got the actual vaginal laser, and they found no difference in treatment outcomes. The FDA warns, like Dr. Moreno mentioned, that there's a risk of adverse events with the vaginal laser. I mean, I would agree with what she said, though. If you try something for you and it works, okay, then it works, but make an informed decision about what risks you're taking. Okay, so here's the take-home for sexual pain. It is caused by treatment-induced menopause. If you're experiencing sexual pain, stop having painful sex. Think about step 2, some over-the-counter options or some behavioral options like moisturizers, lube, a new sexual menu, vibrator, and then think about prescription options. And if your doctor has told you, no, you can't possibly be on estrogen, push back. Tell them to do their research, tell them to do their homework, or tell them to refer you to someone else. All right, now let's talk about poor body image. This is going to take us to Kelly. Kelly says, I can't even look at my breasts, let alone let my wife look. I haven't let her touch me since my surgery. So with breast cancer and body image, and again, I don't have to tell you all this, you know this, it is hard to want to be sexual when you don't feel sexy. Or if you don't think your partner is going to find you or your breasts attractive, and then these negative thoughts are really distracting. Like I mentioned before, I ask my clients, when you're having sex, what is going through your mind? And if your answer is, I am just thinking about how disgusted I feel with myself, how my body's not the same, how my partner probably feels that I'm disgusting. Oh, how that's going to take a hit on desire. That is not sexy. That does not allow you to be in your body. Dr. Moreno touched on this. Mindfulness. Mindfulness is an evidence-based treatment. When you have these distracting thoughts and cannot get back in your body, mindfulness helps with this. So what is mindfulness? It is being fully present in the moment without judgment. So non-reactive awareness is sometimes what this is called. So let me describe this. Imagine if you've had, so let's say you've had a lumpectomy, and you're touching your breast, you can feel the lumpectomy, and you think like, this is horrible, this is painful, can't believe what's happened to me, and that's what's going through your mind. Instead, if you use mindfulness, what you'll do is you'll touch that area, and with non-reactive awareness, just describe, again, without reactivity, what you're experiencing. Okay, so I feel like a moderate pressure, feels kind of cool, feels a little hard. You've taken the reactivity out of how you're connecting with your body. That is really powerful. It is really powerful to be at least neutral with your body versus just beating your body up the whole time. And that is what mindfulness allows you to do, to connect with your body, at least at the start, in a neutral, non-reactive way. It has been shown repeatedly in women and in breast cancer survivors that it improves sexual desire, sexual arousal, and reduces sexual pain. So when you learn mindfulness and bring it into your sexual connection, whether that's a connection with yourself or with your partner, it has major, major benefits. So, if people are taking photos. You can do mindfulness solo. You can do it with a partner. You don't have to have a partner to do mindfulness. You can do it any time. And we're going to do it right now. We're going to do a 3-minute exercise. Usually, when you're first learning mindfulness, one of the best exercises to start with is a mindful eating exercise, but not all of us have food on us. So we're going to do a little bit of a different exercise. And I'll set a timer on my watch for 3 minutes. But what I want all of you to do is, can you just take one object, your phone, your glasses, a pen, just one object. So I want you to pick one object. So make sure you've all got that object. Okay. Now let me set my watch timer for 3 minutes, and I'm going to guide you through an exercise. So I want you to take that object. I'm going to take this remote. But I want you to have what's called a beginner's mind. And a beginner's mind means you've never seen this thing before. So if you're holding your phone or a pen, you know in your mind, like, this is my phone. But in a beginner's mind, you've never seen this. You don't even know what this thing is. So I don't know what this is. I'm holding this object. So I just want you to hold it. And at this point, you're just looking at it. You're feeling it on your hand. And in your mind, I want you to describe non-reactively, just factually, almost like you're a video camera, and just describe what you are feeling and what you are seeing. So for example, I'd say, like, I'm feeling like a little bit of weight on my hand. It feels smooth. It's a little rough on the side here. So I'm just describing. So we take this object and for a moment just describe. all the things you see about it. When you lift it up, when you put it toward the light, do you see the light react on it in any way? All the things you can describe factually without any sort of judgment. The next, I want you to take a finger and just touch the object. And just, again, factually. So like I feel like a divot here, a bump here. This is kind of rough, this is smooth. So in your mind, you can move the object around, but I want you to describe factually everything you feel on this object without judgment. So it doesn't mean things are ugly, just it's like, oh, this is smooth, this is round. Okay, next, I want you to take the object and I want you to smell it. So start with one nostril, and really kind of pay attention to beginning, middle, and end of the smell, and then bring it to the other nostril. What do you smell? Non-reactive, just try to describe without any sort of judgment. Then next, I want you to take it next to each ear, and you can kind of rub it in between your fingers, but what do you hear just factually? What are you hearing? Non-reactive description, and make sure you do each ear. I hear kind of like a clicking sound. And then the absolute last thing, if you're not worried about germs, is to put it next to your lips. I'm going to see what that feels like. And also notice, like, are you salivating? Do you notice anything in your mouth or throat? What do you feel? Okay, our 3 minutes are up. So that was a 3-minute mindfulness exercise with this object. I'm really curious, what was that experience like? Anyone want to share? Yeah.
I chose a ring.
You chose a ring
Wear every
that you wear every single day.
and just to be brought to awareness of, oh, look at that. I didn't realize. I just fell in love with my ring again.
Oh my goodness, I'm going to repeat what she said for those of you who didn't hear. This is a ring that she wears every single day. It brought this kind of high awareness toward her ring that, quote, I fell in love with again. That's awesome. Yes, and 3 minutes of just being with this object that you see it's on your body every single day. Now imagine doing this with your body. One of the most powerful types of mindfulness is doing a body scan. You can do it solo. You can do a partner. We'll talk about partner in a moment. What we know from the research is that a solo body scan, and so a body scan is exactly what you did with this object, but you're doing it head to toe with your body. Non-reactive awareness, being neutral and just observing your body as is and not trying to change it in any way, that's a body scan. So what the research shows is you get the most benefit out of mindfulness when you do a 20-minute body scan daily. The psychologist who has done the vast majority of research on mindfulness and sexual function, her name is Dr. Lori Brotto. On her website, for free, you can download, she has all of her mindfulness recordings, several of which are specific to sexual health, where you do a body scan and you scan your body for pleasurable or sexual sensations, but she has many body scans that are just completely neutral. If you are interested in this and interested in changing your relationship with your body and at least getting more neutral with the parts of your body that maybe you've been upset with or don't feel good about since breast cancer, I would highly recommend downloading some of her body scans and really trying on a daily basis, trying them out. Now there are essentially partnered body scans. They're called Sensate Focus. I'm going to come to these a little later and share the benefit of these, but they're based on mindfulness, so we'll come back to these. Dr. Brotto, same researcher who's done all of this research, she has written 2 great books, Better Sex Through Mindfulness, and then the accompanying workbook, Better Sex Through Mindfulness Workbook. I really like this book, but it is so research heavy. It's not as engaging as that Come As You Are book. So if you're really interested in mindfulness and sexual health, if you're a total research geek like I am, get this. If you're like, no, I don't want that, just get the workbook. Just getting the workbook is just as beneficial. You don't have to get the other book. But it will walk you through how to do these mindfulness exercises. This is a really great TED Talk on mindfulness. So if you're curious about mindfulness, want to hear more about it, it's like a, I don't know, 8 to 10 minute TED Talk. It's not very long, by this guy named Andy Puttycombe, and he is a mindfulness expert. He actually started the Headspace website and the Headspace app, and this is a mindfulness app where you can download it for free for a couple weeks, but every single day, it gives you kind of little mindfulness games. So if you want to be a little bit more engaged in learning mindfulness, you can play these games on your phone. Okay, now lastly, we're going to talk about the avoidant sexual dynamic. We've got to talk a little bit about the sexual relationship before we can go into the avoidant sexual dynamic. If you currently have a partner and you are in a sexual relationship, your sexual response cycles may differ. So for many of you in this room, and this is true for most women, cancer or not, predominantly most women, about 2/3 of women, this circular model, responsive desire, is their main desire. So for most women, and I'll just briefly describe this again, this is how their sexual response works. Sometimes they're spontaneous, and they just happen to be aroused in that moment or seek out sexual stimuli, but mostly they're receptive to sexual stimuli as long as biologically and psychologically everything's in check. Arousal has to get kick-started first. Then that leads to some sort of desire, hopefully leads to some level of satisfaction, and then you feel emotionally close with your partner. So for most women, this is how their sexual response responds. And I cannot stress enough, arousal comes first. There's got to be some sort of touching or something that brings that connection. I have a lot of clients that say it's actually not the touching, it's like a deep emotional talk before any sort of sexual activity. That's what kickstarts as arousal, but there's got to be something that kickstarts the arousal. This cycle may be different from your partner's cycle. So we know about 2/3 of men endorse the linear model. So let me walk you through the linear model. Linear model, it's a line. That's why it's called the linear model. And how it works, pretty simple. It's like a roller coaster. It starts with desire. So this is the spontaneous desire. You just think, I really want to have sex right now. So it starts with desire, leads toward arousal, that leads to orgasm, and then there's a resolution phase, which I call cuddle time. Like, super simple. I want to have sex, my body gets aroused, orgasm, cuddle. You'll see these 3 lines because when this model was originally created, they identified 3 different types of orgasm. This isn't totally relevant, but I'll explain it to you. One type is just one big orgasm, another type is multiple orgasms, and then this last one is kind of one long, small, drawn-out orgasm. Now, what I want you to take from this is your partner's sexual response may be the linear model. The way that they think that desire is supposed to work is, you want to have sex, right? Well, let's just have sex. But if your model is this circular model, you want to have sex is not going to work for you. Something has to kickstart your arousal. Oh, and even before then, all the right ingredients have to be in place. So the way I make sense of this in my mind, I love this analogy. This model, if this is your main model, if spontaneous desire is really where you come from, it's a microwave. You put the food in, you hit a couple buttons, beep, 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 it's hot, super quick. This one is a crock pot. You gotta get those ingredients in place, you put them in the crock pot, they simmer for a while. So sometimes with couples who have 2 different types of desire, one person's more spontaneous, the other's more responsive, they think, oh, they're like, we're never going to match up, our desires are so different. No, it's just a discussion of, okay, we approach desire differently. What ingredients do you in place? What needs to be in your crock pot? Okay, so your sexual response cycles may differ, and your partner may not understand that your main desire is that responsive desire. So talk with them about the ingredients that you need to have in place in order to be responsive, remembering that emotional intimacy is a key ingredient. And the other thing I want you to remember is that your cycle kickstarts with arousal, but your partner's cycle just, like, it's easy, it's a microwave. It's just, I want to have sex. But your cycle has to kickstart with arousal. Now, you're like, oh, that's great, Jordan, but if we're in an avoidant dynamic, if we haven't had sex, we're avoiding sex, then what do we do? It doesn't matter how our cycles start. How do you end an avoidant dynamic? This is where those sensate focus exercises come back in. I mentioned those are those partnered mindfulness exercises. So sensate focus exercises, these are touching exercises, and they're created in a way where there is no demand, there is no pressure, these are just touching. And I tell couples when I prescribe these exercises, no sex. You cannot have sex with these exercises, because if you think that these exercises are just foreplay or a precursor to sex, then in your mind, when you've got these scheduled, you're going to think, "Oh, well, they're just going to turn into sex anyway, so I don't want to do it." So no sex. These are not about sex. So here are the basics, and I'll give you a link where you can download these basics at the end of the talk. You do them in a private space. You set aside anywhere from 20 to 30 minutes. I have some couples that set aside an entire hour. I have some couples that set aside 10 minutes. Whatever length of time you can set aside that will be meaningful, where you really have privacy, that you feel like you can kind of get in that mindfulness zone. So most of my couples do about 20 to 30 minutes. It is 20 to 30 minutes of full body touch. You are nude to whatever extent feels comfortable. For many of you, because of the treatment that you've had, the surgeries that you had, maybe you say, like, I want a shirt on, or I want to keep a bra on. That's okay, as long as you're comfortable. There is no sexual activity allowed, and ideally you're doing these every 48 to 72 hours to kind of keep that momentum going. I have a lot of couples that just can't do that because of their schedules, so at the bare minimum, you're doing these once a week. And there are phases that build upon each other. I'm going to share with you the first phase. So the first phase, full body touching, except in phase 1, there is no touching of breast, chest, or genitals. And there's a couple reasons for this. One big reason is we're really trying to set these up, that these are not sex. These are not sex. So those traditionally erogenous zones are off limits. But the other really important piece, especially with being a breast cancer survivor, is it's just nice to say, okay, chest, breast is off limits. I don't have to worry about that. The rest of the body is going to get explored. So it's a really nice way to kind of ease into these exercises. No sex, I can't say that enough. These are actually nonverbal. So if you think about these as couples mindfulness exercises, that's how you engage in that mindfulness. You're not talking during it. So as you, well, I'll get to this in a moment, you take turns. So if you're doing a 30-minute sensate focus, for 15 minutes you touch your partner all over, then you say switch, for 15 minutes your partner touches you all over. And using your hands and fingers only while touching. I have had many couples try to get crafty and they're like, can I use my tongue? No, hands and fingers only, this is not sex. And so here's a really important piece. You are touching for yourself. And a lot of people are like, what? So think about this. You're touching for yourself. As you touch your partner, you are focused on what you're feeling as you touch your partner. You are not touching to please your partner. You're not touching to give your partner a massage. You are not touching for your partner's satisfaction, because the moment it becomes touching to do something for your partner or touching to please your partner, now you've added pressure. Now you've added some sort of demand, or that has to be some sort of expectation. There are no expectations in these exercises. You get to touch for yourself. Now, as you're touching for yourself, you're focusing on these 3 sensations: temperature, pressure, texture. So you're touching your partner. Is this warm? Is this cool? Pressure, firm, soft. Texture, rough, smooth. TPT, you're focusing on temperature, pressure, texture. Kind of like you did in the 3-minute mindfulness exercise. Like, okay, this is firm, this is soft. These are sensations that are always there. They're vivid, they can capture your attention, and they're always available. If you are really, really interested in Sensate Focus, you can download the first couple phases off of my website for free. Just go to my website /Sensate Focus. This is the only book that has been written about all the different phases of Sensate Focus. It's written for therapists, though, so it's kind of dry. But if you're really interested in going through this and you want to know all the phases, you could get this book as well. So here's the take-home on your sexual relationship. Your sexual response cycles may differ from you and your partner. The circular sexual response cycle may need sexual arousal to kickstart it, and emotional intimacy is a necessary ingredient. If you are in that avoidant dynamic, I want you to consider Sensate Focus as a great way to start to kickstart that touch again without any pressure. And if you are finding that it might be difficult to kind of do that without professional help, then I want you thinking about a sex therapist. These are the places that you'd find sex therapists, especially the first website. That's ASEX, the American Association of Sex Educators, Counselors, and Therapists. There are about 20 of us certified sex therapists here in the state of Utah. And then ISHWISH is another option, the National Society of the Study of Women's Sexual Health. That's a little bit more medical providers, but it's still a good place to find a sexual medicine provider. So here's my overall take-home message for the entire presentation. Breast cancer does not take away your sexuality. Maximize responsivity with those right ingredients and share these ingredients with your partner. If you are having painful sex, stop. Try moisturizers, lubricants, non-penetrative sexual menu, and talk to your doctor about your genital urinary syndrome or menopause. If you're an avoidant dynamic, think about sensate focus, think about sex therapy. Thank you all so much.
We are a little bit over time, which is totally fine. But we can take maybe 2 or 3 questions, if
Sure.
that's okay.
Yeah.
Dr. Rullo will also be on our panel after lunch, and she will also be leading a couples workshop after that. So there will be still some time to ask questions, but is there anything that anyone wants to ask right now before lunch?
You can ask for a friend as well.
Yes. Okay, you guys must be hungry, so let's go ahead and eat. Thank you so much, Dr. Rullo,
Yeah.
and we will be back at about, let's give ourselves till 1:10 since we're a little bit over, and we'll have our Q&A panel in here.